Hello, everyone, and welcome to today's webinar. My name is Kayla Baker, and I will be providing technical assistance during the webinar. Closed captioning and ASL interpreting are being provided. To view the interpreter, set your screen to gallery view. You can switch between gallery and speaker view in the upper right-hand corner of your screen. To view the captioning, click on the CC icon at the bottom of your screen and select Subtitles. All attendee microphones have been muted to avoid background noise and webcams turned off to allow attendees to easily view the interpreters. During the Q&A session, please use the chat box to ask a question. Your question will be read aloud by the session moderator for the presenters to answer. This webinar is being recorded and the recording will be made available for future viewing. It is now my pleasure to turn the call over to Ann Ordway, Program Specialist at the National Institute on Disability, Independent Living, and Rehabilitation Research.
Welcome to the NIDLR-sponsored webinar series on social isolation and loneliness for people with disabilities. This is the third webinar in a four-part series on the research on social isolation and loneliness for people with disabilities conducted by NIDLR grantees and their collaborators. Today's webinar is titled Using the National Survey on Health and Disability to Explore the Experience of Social Isolation and Loneliness among Rural and Urban People with Disabilities. I am very pleased to introduce today's speakers, Dr. Catherine Ipsen and Dr. Gilbert Giem. Dr. Ipsen is the director of the Research and Training Center on Disability in Rural Communities at the University of Montana Rural Institute. She is a national expert in rural service delivery and conducts research focused at the intersection of rural and disability. Her research interests aim to improve health, independent living, and employment outcomes of rural people with disabilities. As part of this work, she has explored the social isolation and loneliness experiences of people with disabilities, developed health promotion and self-employment interventions using participatory curriculum development strategies, and studied effective rural service delivery strategies within the vocational rehabilitation system. Dr. Giem is an associate professor in the Department of Health Administration and Policy at George Mason University and brings research expertise in health economics, program evaluation, and statistical analysis. He has applied econometric methods to analyze multiple large data sets in both evaluation and observational studies, and has over 25 peer-reviewed journal publications in the fields of disability, gerontology, and public health. Doctors Ipsen and Giem are interested in how limits to social participation result in social isolation and loneliness outcomes, particularly for rural people who experience social participation barriers due to geography or place, inaccessible or unavailable public transportation, and inaccessible infrastructure. We'll now begin the presentation.
Good afternoon, everyone, and thank you for joining this webinar, and thanks to Anne for giving such a lovely introduction. I am not going to read the title again, it's a mouthful, but I will say what we're going to cover today just to give people a little bit of the roadmap. We're going to provide some background and context about social connection, social isolation, and loneliness, just so that we're all on the same page when we talk about these different concepts. We're going to provide a little bit of national data to set the stage for understanding differences between people with and without disabilities in terms of experiencing social isolation and loneliness. Then we're going to really use the National Survey on Health and Disability to delve into the experiences of different groups of people with disabilities and explore how different factors play into these experiences. Then we're going to follow up that and look at the experience of social isolation and loneliness pre to post COVID. A lot of the interest that has taken place from NIDLR, ACL, and public health in general has really been driven by the COVID pandemic. And so we wanted to provide a little bit of data looking at that over time. And then we really want to conclude our presentation with highlighting some examples of how Centers for Independent Living have stepped up and really done some changes to their programming and how they deliver services that have really helped people with disabilities address some of these feelings. So I want to just let people know that's where we're headed. So I just want to acknowledge that the research presented today is supported by 2 NIDLR-funded research grants. First, the Collaborative on Health Reform and Independent Living, or CRIL, took the lead in developing the National Survey on Health and Disability, and they have done 3 administrations of that survey, and it really is the source of a tremendous amount of data that people can use and learn more about the experience of disability and health outcomes. And then my RTC, the Research Training Center on Disability in Rural Communities, or RTC Rural. So those are the 2 places where we lift off for our presentation today. I also must say that the findings and conclusions presented here do not necessarily represent the views of NIDLR, ACL, or the Department of Health and Human Services. So what is social connection? Well, social connection is the experience of feeling connected to other people. That's kind of, seems like a Webster definition, doesn't it? It's a basic human need. Our support networks help us weather life's ups and downs. It is very, very fun to celebrate the things that are wonderful to us with other people. And it's really important to have people around us to help us weather some of those times that aren't so great. Social connection helps us build our own self-worth by fulfilling the needs of others. You know, as my mom used to say, when you're feeling down in the dumps, do something for someone else. And I really think that there's something very important about having those social connections and opportunities to fulfill the needs of others. I want to give a shout out to Mark Salzer and Brian McCormick, who did the previous social isolation and loneliness webinar, which I enjoyed immensely. And if people don't have or haven't heard it yet, I recommend it highly. But they talk about a concept of mattering, that it's really important to our basic human need to matter. And we matter when we have roles that we fill within our social networks and community. So that's social connection. So what happens when there's a lack of social connection? Well, it can lead to social isolation and loneliness. And both of these states are associated with some pretty significant decreases in physical and mental health. So more physician visits, more hospitalizations, more cardiovascular health issues, higher rates of depression, higher rates of anxiety, declines in cognition. All of these mental and physical health outcomes are associated with increased social isolation and loneliness rates. So I'm going to hand it off to Gil for this next slide, and he's going to take off from there.
Great, thank you, Catherine. And thank you everyone for joining us for today's webinar. So as Dr. Ipsen mentioned, social connection encompasses 2 concepts: social isolation and loneliness. These 2 concepts are often used interchangeably in various discussions, but from a measurement perspective, social isolation and loneliness are actually 2 very different concepts. So on the slide here, you can see 2 overlapping circles. That reflects that there is a relationship between social isolation and loneliness. They do overlap. However, they do have some key differences. Social isolation from a measurement perspective is an objective measure that indicates a lack of social contact with others. You can think of this as the quantity of interactions that you have with other people within your family, among coworkers, and among friends. Loneliness, on the other hand, is the perception of social isolation, or the subjective feeling of being lonely. So loneliness is a perceived notion of isolation and is related to your expectations about the quality of your social relationship or interactions. So to illustrate just how these two concepts can differ, we may have an example of an unhappy marriage in which you are living with someone day to day, 24/7, and you are not socially isolated based on the number of your interactions with your spouse. However, you may be unhappy in that your expectations of the quality of that relationship with your spouse are not being met. So in this case, you are lonely, even though you are not socially isolated. Another example, you may have an individual who is socially isolated due to the COVID-19 pandemic, and they have a dog. They do not have interactions with family or friends, but through Zoom and computer technology, they're able to get their basic needs met. And the person happens to be happy as an introvert. This would be an example of an individual with a dog who is socially isolated, but is not lonely. Next slide, please. So a lot of the focus for this research will be on loneliness. And loneliness is known to be in the literature to be associated with some of these negative health consequences, both to physical health and mental health. Loneliness is a natural part of our adaptation as human beings. A lot of us experience what's called temporary or transient loneliness, where we move to a new location, maybe we start a new job, or we move to a new school. And we have this temporary state where we don't have strong social connections. In the case of temporary loneliness, Coulter et al. In 2015 discusses the various stages by which we adapt to transient loneliness. It is also called here the reaffiliation motive. And basically, we may withdraw temporarily from social interactions. We become hyper-aware of social cues. And in recognizing the need to build new social relationships, we may re-engage with different people in the community. So for example, if we move to a new school as a graduate student, for example, we may not have any social connections or friends, but the re-affiliation motive spurs us to join a new activity or participate in sports or attend a new church. And in this way, the state of being lonely gradually recedes as a temporary state. In contrast to temporary loneliness, some individuals experience chronic loneliness. This is a persistent state of loneliness that lasts for an extended period and is self-reinforcing. So things such as feeling shy or anxious leads one to withdraw from social interactions. But that individual stays withdrawn and doesn't kind of reach out to try new activity or to meet new individuals. And this negative interpretation of social information can also lead to perceived threats. So individuals in a state of chronic loneliness are uncomfortable or fearful of reaching out to new individuals. So this distinction between temporary and chronic loneliness is important. A lot of our focus in the literature in terms of negative health outcomes are associated with chronic loneliness. You can also think of this as stress. Temporary stress is different from chronic stress. And so we'll draw this distinction in our research as well. Next slide, please. So to provide some context, for people with disabilities, social isolation can also be affected by structural as well as environmental barriers. Certainly having access to timely public transportation is important for many different reasons. This affects the ability to have timely access to medical care, But transportation also helps us to engage in social visits, attending church, seeing friends, and going to work. Accessibility is also important outside the home, where we look at community infrastructure, the design of sidewalks, of parks, medical office facilities, and so forth. And lastly, there can be barriers in terms of accessibility inside the home as well, in our housing environment. And that may make it difficult or cumbersome to leave the home to engage in social visits with others as well. And finally, stigmas can reinforce these structural barriers, which could potentially limit confidence and cause one to be fearful, again, of reaching out and engaging other people. Next slide, please. So if we look at the literature, it's actually quite well established on social isolation and loneliness among older adults, 65 years of age and older. In 2020, the National Academies of Sciences, Engineering, and Medicine released a report on social isolation and loneliness in older adults, and it summarized several years of extensive studies. What this literature shows is that structural barriers are related directly to mobility limitations among older adults. Earlier, I mentioned these temporary shocks, moving to a new school, moving to a new location, moving to a new job. For older adults, other disruptive life changes can occur. So retirement from work, housing changes, as well as bereavement due to the death of a spouse, again, can suddenly put someone in a state of social isolation that is a shock to the system. And with this, for older adults, these life changes or shocks can lead to higher rates of chronic illness and pain. We also know that the loss of established social networks and supports directly leads to social isolation. And approximately 1 in 5 older adult respondents do indicate high levels of social isolation based on the National Health Aging Trends Survey, or NHATS, which is administered by Johns Hopkins University. Despite this extensive literature on social isolation and loneliness in older adult populations, we have relatively limited evidence on the prevalence of social isolation and loneliness among younger adults with disabilities or by specific type of disability. In this presentation, we'll just highlight some of these findings for you, again, focusing on adults 18 to 64 years of age with disabilities. Next slide, please. So one of the first data sets that we explored and examined as part of our research project was to look at the Health and Retirement Survey, or HRS. The Health and Retirement Survey is supported by the National Institutes of Aging and the Social Security Administration, and has been in place since the 1990s. It is a longitudinal survey of adults who are 50 years of age and older nationwide. And we use the HRS to create a baseline comparison to look at social isolation and loneliness prevalence in adults with disabilities and adults without disabilities. In 2006, social isolation and loneliness were both added to the HRS dataset. And the indicators of disability in the HRS reflect work limitations, activity of daily living limitations, or ADLs, and instrumental activities of daily living, or IADLs. And for this analysis, we focused on working age adults who are 50 to 64 years of age. Our main finding was that social isolation and loneliness are more than twice as prevalent among adults 50 to 64 years of age with disabilities compared to adults without disabilities. Next slide, please. So on this slide, you can see the graphs to the left. The focus here is on the prevalence of social isolation, and to the right, the prevalence of loneliness. So on the left, we can see that in our sample of roughly 2,700 adults, 50 to 64 years of age, the prevalence of social isolation is more than twice as high for adults with disabilities compared to adults without disabilities. In the year 2012, roughly 19% of adults with disabilities reported having social isolation, compared to only 9.8% of adults without disabilities. That same disparity persisted in 2016, with 21.5% of adults with disabilities reporting social isolation, compared to only 10.9% of adults without disabilities reporting social isolation. And on the right side, we see this disparity or gap is even greater if we look at the prevalence of loneliness for adults with disabilities. That was 24.6% in 2012, compared to only 8.8% among adults without disabilities. And likewise, in 2016, that gap persists. 21.6% of adults reported loneliness, those who have disabilities, compared to only 9.7% reporting loneliness among adults without disabilities. So one of the main points of this was, again, that the prevalence of both social isolation and loneliness are higher among adults with disabilities. And secondly, the concept or measurement of social isolation and loneliness are a little bit different, so they're not identical. Next slide, please. So we wanted to take a deeper dive, given this higher prevalence of social isolation and loneliness among adults with disabilities. We are going to use the National Survey on Health and Disabilities to look at a convenience sample of adults with disabilities 18 to 64 years of age. This is a national survey that is supported by a NIDLR, by the CRIL, as well as a recent field-initiated program grant. And although the results of the NSHD cannot be compared directly to the Health and Retirement Survey because the age bands are different, the NSHD consists of 18 to 64-year-olds compared to only the 50 to 64-year-olds. And also the NSHD only includes adults with disabilities. It does have the advantage of providing a much deeper dive and giving us much richer, fine-grained information about social isolation and loneliness among people with disabilities. So with that, I'll turn it back to my colleague, Dr. Catherine Ipsen.
Hi. Oh, I haven't talked for a minute. Okay, so first of all, I just want to do a little overview of the NSHD and highlight that the NSHD asks about disability in several ways. And it provides an opportunity, because of all these different ways that disability is asked, to have questions that you can compare against different surveys, and also to look at different ways to examine disability, if it's based on functional disability or self-identified disability types. So they have questions that came from the American Community Survey. There's 6 questions that focus on functional disability, yes/no questions. They have questions from the Washington group that has functional disability as well, but asks degree of impact, or how often that functional disability impacts your daily living. And then they also included a second measure based on self-identified disability types. And they asked that both on self-identified, as people just selected a category, and then they also asked open-ended responses where people could describe their disability, and those were classified by researchers into some specific groups, including mental illness, psychiatric disability, physical disability, IDD, and autism spectrum disability, sensory disability, neurological, and chronic illness. And these are the aspects of disability that we are going to focus in on today. But there's many different ways of looking at the data, and we have some specific reasons for doing that that I won't go into here, but I'm happy to describe later. So So far, there's been 3 waves of the NSHD administered, and we are going to focus on wave 2 and wave 3. I'm going to first focus in on wave 2, which is data that was collected in the end of 2019 and very early 2020 that gives us a pretty robust sample of how people were experiencing social isolation and loneliness prior to COVID. And then I'm going to follow that with some longitudinal data from the wave 3 NSHD administration that includes data that was collected approximately 1 year after all of the lockdown and social distancing measures were in effect. So before we get going, I want to talk about some of the measures that were collected in the NSHD and the ones that I focused on primarily in the analyses that were pre-COVID. So first, there's questions. I am satisfied with my current level of social activity. People could respond to not at all to very much. We looked at quantity of social connections. So how big is the network of close contacts you see or hear from each month? And people could respond, it was open-ended, they could respond however many they had, but it was coded 0 to 9 plus, so 0 to 9, and 9 could represent kind of an upper limit of contacts. We also looked at quality of social connections, and that was measured by when you have an important decision to make, do you have someone you can talk to about it? That was anchored from 0 to never to 5 always. So in all of these items, a higher score indicates more social connection. A lower score means more social isolation. The NSHD also collected data using the 3-item UCLA loneliness scale, which is very common measure across data sets, which makes it attractive. And it asks 3 questions. How often do you feel you lack companionship? How often do you feel left out? And how often do you feel isolated from others? And people could respond to each of those questions with a 1 hardly ever to 3 always. So the total loneliness score, which adds these 3 items together, has a range from 3 to 9, where a higher score indicates a higher rate of loneliness. So I just want to make that distinction, because when you're looking at outcomes in the data, I want you to remember that a higher score of satisfaction with social activities or social connection is good, and a higher score of loneliness indicates a degraded state. So we wanted to find out a few things, or we wanted to understand the experience of social isolation. First, in terms of what factors predicted social isolation and loneliness amongst different groups, social demographic characteristics, disability type, and some environmental factors, including rural and urban geography, transportation access, living situation, and employment, socio-demographic was employment. And then, did rates of social isolation and loneliness change in response to the COVID pandemic and the March 2020 lockdowns in the US? And were these differences consistent across rural and urban samples? So that's kind of what we wanted to find out. I'm going to give just a quick rundown of the characteristics of the NSHD sample. It is not, and I am going to highlight that this is not weighted data. We wanted to keep the data as pure as it could be, especially when we're looking at experiences of social isolation and loneliness and trying to describe these experiences with a certain degree of accuracy for the people that were surveyed. So the sample was approximately 65% over the age of 35, and that goes up to 65 or 64, I should say. 33% were male. Approximately 19% were not white, not Hispanic. Very educated group of respondents. I want to highlight that. About 86% had at least some college, and 63% were employed. Approximately 36% lived at or below the 138% of the federal poverty level. The disability statistics that I'm gonna just talk about briefly, I want to highlight that people could indicate having more than one disability. And so I want to highlight that this is not going to add to 100. These aren't distinct groups, and nor should they be. People can bring all sorts of different qualities to this data, and one of it is having more than one disability and one disability type. So this included 46% with mental illness or psychiatric disability, 37% with physical disability, 44% with chronic illness, 7% with IDD or autism spectrum disorder, 9.7% for sensory disability, and approximately 28% with a neurological disability. We ran different analyses for each of the outcomes of social isolation and loneliness. And I'm going to just report specifically here about the analysis of loneliness. So the outcome variable was the level of loneliness, and what went into that model were socio-demographics, including race, education, gender, age, 138% of the federal poverty level, and employment. Disability type was the disability types I just listed and went through. And then environment was rural versus urban, and whether people had transportation for problems for daily needs and transportation problems for social needs. Included in the NSHD, there was a question, a series of questions about things you are not able to do because of transportation problems. And they included work and school and running errands and going to the doctors, socializing, and community events. And we left off work and school because many people didn't work or go to school, so it wasn't one that was compared across groups. But we classified transportation problems for daily needs as including running errands and going to the doctor, and transportation problems for social needs as needs not meant to socialize, recreate, and go to community events like church, and then living alone. So what were the significant predictors of loneliness? When being not employed, having a mental illness or psychiatric disability, and transportation problems related to social needs. And I want to highlight that because the beta is 1, which is a very large difference. So if people said that they had problems accessing transportation for social needs, their level of loneliness increased from 1 point. So they might have gone from a 5 to a 6 or a 7 to an 8, which is a really quite a large impact when you take into consideration all the different variables that went into describing loneliness scores. Other predictors were living alone and being at 138% of the federal poverty level or below. So all of these significant impact or indicators increased the experience of loneliness. So I don't want to go into all the different models. It's a ton of data, but I wanted to talk about predictors across models and highlight that there's some predictors that would, maybe they impacted quality of contacts, but none of the others. And the ones that stood out or really held up in every single model for social isolation and loneliness were employment, having mental illness or psychiatric disability, and then transportation problems for social needs. And I think that this highlights some of the groups that might deserve some focus and programming, and looking really at the value of employment as a protective factor of all sorts of things beyond your kind of economic well-being, and then transportation. So I want to highlight that even though I'm a rural center and love to find rural findings, there really wasn't a whole lot of difference between rural and urban locations, except for quantity of contacts, where rural location impacted the number of people you were connected with. And, if we really think about this, this isn't overly surprising. A lot of people move to less crowded people if they don't, or less crowded locations if they don't emphasize kind of having big social networks and social opportunities. So that was something. Okay, so then the pandemic hits, and there is such a new focus on social isolation and loneliness among the population. So prior to COVID, the US Surgeon General called the rising prevalence of social isolation and loneliness a public health epidemic. And this was in 2017, Dr. Vivek Murthy. In March 2020, the lockdowns and mandatory social distancing really elevated this experience of social isolation. And in the news, it was sometimes referred to a double pandemic, where people's health issues were really doubly impacted by COVID-19 and the new experiences of social isolation and loneliness that went in with those protective measures. And there was a disproportionate impact on vulnerable populations based on what they needed to do to keep themselves safe from COVID-19. It exacerbated prior health disparities, and there were a greater risk of mortality and complications if exposed to COVID-19 for certain populations, including older adults, people with disabilities, those with pre-existing health conditions, and of course, some different demographic groups. So I was talking about this presentation and with Keith Christensen, who is a PI on another NIDILRR grant. So we're going to pull in one more NIDILRR grant on the socio-ecologic framework for supporting individuals with disabilities, community living, and participation. And when COVID hit, they shifted some of their work to really look at how COVID was changing the experiences of people with and without disabilities over time. And they had collected data prior to COVID-19, and during that time, people with disabilities reported significantly lower rates of social satisfaction than people without disabilities. So they're starting from different points. In early December 2020, those differences between people with and without disabilities were no longer present in the domains of home, work, grocery shopping, going out to restaurants, retail, indoor recreation, worship, education, community service, or online engagement. So while people without disabilities had some significant declines in their satisfaction with social participation, those declines far outpaced people without disabilities, and there were no longer measurable differences between the two groups. There was, however, differences in social satisfaction with outdoor recreation and healthcare appointments that were continued to be significantly lower for people with disabilities compared to those without. And I think that this is makes sense, particularly the healthcare appointments. It's a group that really potentially has more healthcare appointments to attend, and the way that those services were shut down as COVID appointments took over the healthcare availability, I think probably had a significant impact. So I just wanted to bring in that data to really highlight how these experiences can be different between people with and without disabilities. So the comparison of wave 2 and wave 3 NSHD data really showed that these differences really don't play out always as you expect. So first of all, pre to post COVID, people with disability reported higher rates or more satisfaction with the amount of time that they had to participate in leisure activity. There were no differences between social activity, and then they were isolated from others in the community at much higher rates. So that follows how we might expect it to go. What was really surprising, however, is that there wasn't any differences in quantity or quality of contacts. And there also was an improvement, not a degradation, an improvement in their loneliness scores, meaning that they felt less lonely. And a lot of that really, I think, highlights how loneliness is a very subjective experience, and we evaluate how we're doing in relationship to how others are doing. So I am running out of time, I know. So I am just going to highlight really the role of how CILs help to maintain social connections from the field. And these are phone call transcripts from rural conversations that were administered by the Association of Programs for Rural Independent Living and the Independent or ILRU, which the Independent Living Research Utilization Program, another NIDIR grant. But here are some comments from those. CILs have scrambled to provide accessible ways for consumers to connect for peer support, both virtually and in person for those without technology to combat social isolation. I have not found consumers looking for resources as much as I have consumers who simply want someone to listen, and peer support virtually has really moved up to the top of our core services list. And then I think these isolating lockdowns are bringing a large number of people all at once into our disability community. And I just want to highlight that the emphasis on peer support, shared experience, and transition to online delivery methods has really been potentially an example of why these social isolation rates aren't degrading. I'm going to skip this one and pass it back off to Gil.
Okay, so thank you, Catherine. To close off our presentation, in terms of findings, we saw that social isolation got worse after COVID-19, but loneliness did not. Temporary social isolation can lead to loneliness for people with disabilities. CILs have played an important role in overcoming temporary social isolation by conducting Zoom calls and support meetings through Zoom. Chronic loneliness, however, will require more comprehensive programming, And SIL peer support models, both in person and virtual, can play an important role in that regard. Next slide, please. So in terms of conclusions and implications from this research, the first is transportation is a key barrier to participation and affects not only employment, but social activities and loneliness. Employment is also a consistent and independent predictor of social connections and loneliness. So policies to support employment among people with disabilities can also reduce loneliness. And lastly, SILs play a key role in building social connections and reducing temporary loneliness. But expanded support for peer support services and more research and evidence on interventions and their effectiveness are needed to address chronic loneliness. Next slide, please. So with that, I'm going to turn it back to Anne Ordway. Feel free to enter your questions in the chat box, and we'll enter a period of Q&A at this point.
Thank you so much, Catherine and Gil. That was a wonderful presentation, and I know you felt a little bit rushed at the end, so we might go back to one of your slides on the Centers for Independent Living. I do want to open up now from the audience. If you have questions for the presenters, please put those in the chat box, and I'll be monitoring the chat for those questions. And as I traditionally do, I may lead off with a question of my own, and I kind of want to get back to that question of rurality. So let me pull up my question here. So the pandemic, as you've noted, has shined a light on the topic of social isolation and loneliness. And as I've talked previously in previous webinars, that it's also challenged our assumptions about who is socially isolated and lonely. And I imagine that most of us here in the audience would assume that rural individuals are more likely to be socially isolated and lonely, but that's not what you found in your studies. So as experts in rurality, help us to understand this finding by perhaps explaining, Catherine, something I think I've heard you say, or maybe was in the slides, about the rural psyche or the rural standard. So after explaining this, then also tell us, do your findings suggest that we should not focus on rural people when it comes to social isolation and loneliness?
Good questions. First of all, I absolutely don't think you should not focus on rural people for social isolation and loneliness. I think that I am not saying that rural people don't experience social isolation and loneliness. I just am saying that they don't experience it significantly more in certain domains. I will go on to say that they do have lower support networks. They have smaller quantity of support networks. And as we kind of touched on at the very beginning of the presentation, those social connections that get cut off can often leave you a little bit adrift for a time. And as you are trying to build up new social connections, having a network to help build that up really can help you move from that temporary state back into not feeling lonely. And for rural people, if you have a support network of 3 versus 5, that can make a difference if 1 or 2 of those is no longer available to you, or you have needs. We have just been doing some other research on personal assistance services and the great degree with which people have had to rely on family and friends to overcome some really horrific conditions based on COVID-19 impacts. And that's a great example of where those social networks and the ability of sharing that across people is important. I don't know. Yeah. And in terms of the rural psyche, there is a rural psyche. I live in a more rural place because I like less contact with people. However, I have really rich relationships, maybe just not as many of them. So.
Great, thank you for that. And I have some methods questions coming in from our researchers in the audience. So question, what was the range of missing data? What was the range of missing data? So I guess, was there missing data? And what was the effect of the age distribution? Pre-post was age adjusted.
Pre-post was not age adjusted. It was a 1 year snapshot of the same people. Okay, so that's that question. In terms of missing data, I did not do anything to address missing data. We only used people who answered the full set of questions in both waves.
Great, and thanks. I have a question coming in now about the Centers for Independent Living, and this may have been one on one of your slides, but they wanted examples of how the Centers for Independent Living are helping to address social isolation and loneliness.
I'm gonna try and go up and touch on that. So an example that came really from some of the work that we do here on the Living Well in the Community Health Promotion Program, which we were running research in the midst of COVID, and how did that continue on? And CILs seamlessly supported one another in making those transitions to online delivery. They developed and shared video instructions for how to run Zoom meetings, how to get on, how to use the chat box. They encouraged participants to overcome digital hesitancy and continue participating in peer programming. And actually, in some ways, and this could potentially explain some of the differences in, or the lack of increases in loneliness score, is that a lot of people went to attending more often than less often in some of these programs, because there were no longer barriers, structural barriers in terms of transportation and getting out of the house, even though you're experiencing pain and fatigue. And so I feel like, particularly for people with disabilities, building digital literacy at the same time that they're experiencing maybe some new constraints in social participation, the balance of that was to actually increase opportunity, not lose opportunity, as a lot of the social engagement changed to online. That increased opportunity. I heard about participants exploring, like they overcame digital hesitancy, and then they were joining quilting groups, and they were doing online searches, and they were having Zoom meetings amongst themselves. So they were figuring out how to engage. And prior to that, I felt like, or I didn't feel like, I heard from on these calls that people had said, I didn't feel like I was supposed to be literate digitally. People didn't encourage me to do that. They didn't expect me to have those or build those skills. And afterwards, that really, apparently, it wasn't that big of a deal. And then it opened up a lot of other opportunities.
So Catherine, along with that, this conversation about the roles of Centers for Independent Living and social isolation and loneliness, I'm wondering, just for our audience, do all individuals with disabilities have access to a Center for Independent Living? And also, can you talk about, are there individuals that a Center for Independent may systematically miss, or groups of individuals?
I can't speak for all Centers for Independent Living. There's a lot of them. There's more than 300 Centers for Independent Living with multiple satellite programs across the US. And I would say that, yeah, all people can access Centers for Independent Living. There have been times when Centers for Independent Living, I think, do a better job outreaching to certain groups, and may have different skills and strengths based on who's working at the Center for Independent Living. But I don't want to say anything general about Centers for Independent Living because they're, unique entities comprised of different people with different strengths and outreach strategies. So.
Great, thanks for that. And this is just a comment in the chat. Someone had said that volunteer opportunities could be a wonderful opportunity. If there isn't employment, volunteer opportunities can offer a wonderful opportunity for social connectedness. And this kind of harkens back to our presentation from last month. So I'm just promoting that one, which is archived, and you can find the link to that and watch, but around something that Temple University is doing by looking at volunteer opportunities and the construct of mattering. But Catherine and Gilbert, did you want to talk about volunteer opportunities and their relationship to social isolation and loneliness or social connectedness?
I'll let Gil take that one.
Sure. So I could just, briefly note that as part of how we measure social isolation, it is the, frequency of contacts, right, with others. And I think volunteering is really an important way of engaging in community participation. So that can be volunteering for a nonprofit organization. It could be volunteering in your local church or even in some other capacity. But it's the kind of this frequency of social interactions that then has a relationship with the quality of those interactions over time. So volunteering does play an important role. I wanted to just briefly mention or kind of address the question of, should we fund research or support research on social isolation and loneliness in rural adults and people with disabilities? I would say wholeheartedly yes. In the HRS, we saw the prevalence of both social isolation and loneliness was more than twice as high among adults with disabilities, 50 to 64 years of age, compared to adults without disabilities. So given that, I think the potential challenges, the unmet needs associated with loneliness are potentially higher or more severe in these populations. And even though there may not be sharp differences between rural adults with disabilities and non-rural adults with disabilities, I would argue that the prevalence of disability is fairly high or growing in rural areas, which are also aging. We do have some evidence from the literature of older adults, 65 years and older, but I would argue that working age adults with disabilities, 18 to 64, have some systematically different needs, different opportunities to engage in the community, different avenues for volunteering. So some of the structural barriers are similar across these two populations, but I think the extent of unmet needs and the range of how individuals can participate in the community differ. So that warrants continued support of ways really to kind of address chronic loneliness and to monitor the prevalence of social isolation and loneliness in adults with disabilities, both in rural areas as well as non-rural areas.
Great, and then what the final question for the hour, and comes in a couple different ways, but I'll read this verbatim. Given that rural residents may have different perceptions of what it means to be lonely, are there any other methodological approaches that might more accurately capture the rural experience of isolation and loneliness? And then relatedly, there was a comment that, how are you looking at rural urban? Is that dichotomous? And maybe that's not the way it should be measured as a dichotomous construct, but that there's gradients or other ways to capture that. So I'll let both of you respond.
I will respond on the second one. So we captured it based on county of residence, and counties can be classified as metropolitan, micropolitan, or non-core. And metropolitan or having an urban area greater than 50,000 people, metro having an urban area of less than that, but greater than 10,000, and then non-core falling outside of that. And there are absolutely distinct differences between those groups, particularly between the non-core, who don't have kind of access to, I guess I would say, a lot of community-based resources, be they healthcare or transportation. The problem is that we didn't have the numbers to really look at the non-core group independently. And when you look at urban and rural definitions, the metro or the micro and the non-core both fall into rural. So that's how we did it. But there are definitely better ways to capture that, or different ways to capture it. It is a data issue in terms of confidentiality and how much information you can get to about individuals. To give you an example, some of the like census data that is kind of individual data that people can get access to, that is merged up to groups of 100,000. And if you are trying to get a rural area independently, like a non-core counties, those have a very hard time getting aggregated up, and they often get merged with those bigger metro counties. So it's a data issue.
And I'm sorry, Gilbert, did you want to add something really quick? I've taken us over as usual. I haven't been a great timekeeper, but no, Gilbert, did you have anything you wanted to add real quick?
Yes, so just for the first question about perceived isolation and loneliness, so we don't have a direct way to control for differences in the rural kind of definition of loneliness versus urban. But we are exploring the NSHD to look at kind of other differences of the perception of need. And there we see some interesting differences between rural and urban populations. But because loneliness is defined by perception, Dr. Ipsen is perfectly happy being remote from me and not having a face-to-face interaction. I, on the other hand, prefer social face-to-face interactions. We can't control for that difference. Both are in terms of loneliness, but the perception or expectations of the quality of that relationship, we're delving into that now as part of our ongoing research.
Wonderful, thank you. And I think that's a great note to end on, even though questions keep rolling in. It's been a wonderful presentation. Thank you both, and thank you, audience, for participating. And Caitlin, I'll hand it back over to you.
Thank you for attending today's webinar. This concludes today's event. An email will be sent out to participants with contact information for today's presenters, as well as a link to the recording once available. The recording will also be archived on the NARIC website, as well as ACL's Commit to Connect page. You may now log off at any time.